approach your theory paper. All right. And I'll also tell you how to keep calm, what to do, what not to do. And all of these sessions, all of these things will be covered in this particular session. All right. Yes. And we here at Oracle, we offer you live sessions, recorded sessions, notes, and MCQs. And all of the content that we curate over here is based on the CBME curriculum. And live classes are particularly helpful for you to keep on track, and also to, you'll have an educator who is teaching live and you can get your doubts clarified live. And if you still have any doubts, you can obviously go and watch the recorded lessons. Then we have the notes, which are very crisp and concise, and this is again based on the CBME curriculum. And MCQs will definitely help you in your upcoming next examinations. And you can also book a personalized counseling session with us. You will be given a mentor, and that mentor will help you to, you know get anything and everything clarified under the sun, whether it is academic and otherwise. He can be like a good friend and a buddy to you. And they will analyze your strengths, your weaknesses, areas in which you need to improve, how to study, and you can share with them anything and everything basically. These are the three different plans that we have: basic, standard, and premium. And you'll be getting just the pre-recorded class and the live sessions and the quick revision sessions in the basic plan. And in the standard plan, you'll also get the live doubt clarification, but the premium plan offers you everything: live doubt clarification, one-on-one personal guidance, pre-recorded classes, live classes, and everything. And you can of course use my coupon code Dr.Sushma 20 for any additional discounts. And today's topic is axilla. See, axilla is the only thing that I'm covering in this topic, but I'll also be mainly concentrating on how to approach questions. That is my primary focus in this, but also I'll cover up axilla because I think axilla is the only topic that is left out, which is important in this revision series. Okay. And this is the schedule that we had, and today is the last class that we are doing. After day after tomorrow, we are going to be starting with the neuroanatomy. And yes, so this is the clinical case scenario. Let's begin with the class. A 38-year-old female comes to you with complaints of nipple discharge and a lump in the breast. On examination, axillary lymph nodes are palpable. What percentage of lymph from the breast gets drained into axillary lymph nodes is the question. Okay. This I've already covered in the previous class, and this is, as I said, this is a revision class. About 75% of the lymph from the breast gets drained into the axillary lymph nodes. That makes the axillary lymph nodes extremely susceptible to breast cancer. Okay. Now, if a 38-year-old female who is non-pregnant coming to you with the complaints of nipple discharge and lump, so the first thing you will suspect is obviously malignancy. And also the axillary lymph nodes are palpable. That means it has already spread to the lymph nodes from the breast, and about 75% of the lymph drains from the breast to the axillary lymph nodes. All right. Yes. Now, these are all the different topics that I want to cover today: how to approach 10, 5, and 3 marker questions, long essay, long answer, and short answer. Then how to what exactly happens in a practical examination, right? What you will be given, what you need to do in your practical examinations, and how to study histology. Again, this is one of the topics or one of the things that you take it for granted. Because you take it for granted, towards the end what happens is histology gets piled up like one big thing in your head, and then before going to the exam you're scared. So I'll tell you how to go about histology as well. Most importantly, how to keep calm during examinations. A lot of times what happens is we, as students, even though we would have studied everything, even though we know a lot of things, but we somehow screw up and come in a practical examinations simply because you lost your nerves, simply because you're extremely scared, simply because you are tensed up. So I'll tell you how to approach your exams and also how to keep calm. So before that, let's just be done with axilla. Okay. So what is axilla? Axilla is the armpit, right? It's a pyramid shape between upper part of arm and the side of chest. So if axilla is asked, the first definition is axilla is a pyramid shaped structure between the upper part of the arm and the side of the chest. What's the function of axilla? It forms an important passage for nerves, blood, and lymph vessels as they travel from the root of neck to the upper limbs. If you remember, guys, if you remember the initially when I taught you brachial plexus, what was the basic definition, or when I told you the extent of brachial plexus from the where are the roots are in the posterior triangle, from there it comes to the neck, and then it goes behind the clavicle, and finally it enters the axilla, if you remember it correctly. So basically axilla is an important passage of nerves, blood, and lymph vessels. And you can imagine, if there's any injury to axilla, if there is any injury to axilla, you will have major side effects. Okay, you'll have major manifestations if there is any injury to axilla. Axilla, as I told you, has an apex, base, and 4 walls. Okay, axilla has apex, base, and 4 walls. What are the 4 different walls that I have? First, we have the anterior wall, then we have the posterior wall, then I have the medial and the lateral walls. Medial and lateral walls. Okay, axilla has an apex, base, and 4 walls: anterior, posterior, medial, lateral. Understood? Yes. Then apex of the axilla. Apex is upwards, right? It is the upper end of axilla. It continues into the root of the neck, that is up until the posterior triangle of the neck through the cervico-axillary canal. Next, what are the boundaries of the cervico-axillary canal? The name only says it is in front, bounded by the clavicle. Behind, it is bounded by the upper border of the scapula, and medially by the outer border of the first rib. Look at it, guys. So if you look at axilla, if this is the clavicle and this is the first rib and this is the serratus anterior and the superior border of the scapula, this is the area that I'm actually talking about. That is the apex of axilla, right? Then what is the base of axilla? Base is the lower end. Base is always in the lower end. No? Apex is upper end. Base is the lower end. Base is formed by the skin stretching between the anterior and posterior walls. And what are the boundaries of the base? See, every point that I'm telling you right now is important for us. Okay. In the front, it is bounded by the anterior axillary fold. Behind, it is bounded by the posterior axillary fold. Medially by the chest wall. This is just like a triangle. Okay, the base of the axilla is like a triangle, and the anterior axillary fold is formed by the lower border of the pectoralis muscle. Posterior axillary fold is formed by the tendon of latissimus dorsi and teres major muscle. Medially, it is bounded by the chest wall. Every point that I'm mentioning right now is important. Okay, this is the base. If at all you have a question that is coming from axilla, you will have to write this simple kutti line diagram. What is this? This is the fourth rib. This is the serratus anterior. This is the subscapularis muscle, teres major and latissimus dorsi, and this is the pectoralis major muscle. And this triangular portion is what I'm calling as base. Okay. Then walls of the axilla. Until now, what have we finished? We have finished the apex and the base. Now it is a pyramidal structure, na? So I've done the apex and I have the base. Now I have to do the walls. Anterior wall is formed by the pectoralis major, subclavius, and the pectoralis minor muscle, that you can remember as PSP muscles. Anterior is PSP muscles. Posteriorly, it is bounded by the subscapularis, latissimus dorsi, and teres major muscles, right? And the medially, obviously, anything and everything that is in axilla which is medial has to be related with the ribs, isn't it? If you look at the armpit, anything that is medial to it is obviously chest wall, it is obviously the ribs. So the medial wall is bounded by the 4 or 5 ribs, and the intercostal spaces, of course, covered by the serratus anterior muscle. Is there anything to mug up over here? Lateral wall is formed by the coracobrachialis. How do we remember this? Lateral. L is coming in brachialis. Lateral is formed by coracobrachialis, and the biceps muscle in the bicipital groove of the humerus. Again, a question. I keep asking this question in every single class. What muscles are there in the bicipital groove? What muscles are there in the greater and the lesser tuberosity of the humerus? You will have to answer this in my next class. Okay. Anteriorly, it is bounded by the PSP muscles. Posteriorly, all of the posterior muscles, like the latissimus dorsi in the posterior side, right? Dorsum meaning posterior. Teres major, where is teres major coming from? Teres major is coming from the scapula, isn't it? Subscapularis and teres major are coming from behind. So obviously, they form the posterior wall. Medial wall, chest wall. Lateral wall, lis. Lis is lateral, like coracobrachialis and biceps. Nothing to memorize here. Just apply logic. Anterior PSP, posterior all the posterior muscles, medial the chest wall, lateral the lis muscle. Yes, this is what is showing the different muscles, like how they are coming. Yes. Anterior wall, as I told you, is by the pectoralis major, subclavius, and the pectoralis minor muscles. All right. And you can see here, medial pectoral nerve. And medial pectoral nerve, question to you, is a branch of which cord? Yes. And the posterior wall is formed by the subscapularis, latissimus dorsi, and the teres major muscle. You can write this kutty simple diagram in your exam. Okay, look at it. Look at it, guys. How the subscapularis muscle, which is coming from behind and getting inserted into the, into the humerus, forms the posterior boundary. So the axilla is in front of it. You can see the tendon of biceps, which is coming like this, right? The axilla is in front of it. Medial wall formed by the upper 4 or 5 ribs. There is nothing to memorize. Anything in axilla is chest wall. Anything in axilla you can write as anything medial in axilla is obviously related to chest wall. Either it has to be related to ribs or it has to be related to intercostal space. Makes sense, right? Or it has to be related to serratus anterior muscle. Okay, so always, guys, in anatomy, just apply logic. Once you apply logic, it's going to solve many questions to you. You need not have to, think 100 times, or you need not have to mug up. Okay, like for example, in this very topic that I'm teaching you, anterior wall is PSP muscles. Okay, pectoralis major, subclavius, and pectoralis minor muscle. Again, there is a logic. These are all the muscles which are there anteriorly. Posteriorly, it is bounded by muscles which are coming from the back. Whenever I say muscles which are coming from the back, the one muscle that should come to your mind is obviously latissimus dorsi. Why? Dorsum meaning back. Dorsum meaning something that is in the back. Latissimus dorsi is the muscle. Obviously, will have to form a posterior boundary. Isn't it? So, what are the other muscles that you can think of? Like subscapularis is another muscle. All right. Then, as you can see, subscapularis, latissimus dorsi, मान के चलो कि teres major भी अगर याद नहीं आया तो भी ठीक है, because you can always write subscapularis and latissimus dorsi as your answer. Okay. फिर medial wall is formed by, again, anything and everything in axilla. If you look at a pattern, how it is, right? Medial is obviously formed by the chest wall, that is 4 or 5 ribs. Now, what are the contents of axilla? One content we have already covered is the brachial plexus. We have gone in detail with brachial plexus. An entire hour I have taught brachial plexus. And of course, axillary lymph nodes as well, we have already covered in a previous class. So the contents of axilla, very easy. Axillary artery, vein and lymph nodes, and brachial plexus. Now, I have just taken up axillary artery because I feel, I want to do this in a little more detail. Okay, now the axillary artery begins at the lateral border of the first rib as a continuation of the subclavian artery. Okay, subclavian artery, axillary artery, brachial artery, radial artery, ulnar artery. So this is how the structure or the arterial structure of the upper limb is. Then termination at the lower border of the teres major muscle, it continues as the brachial artery. Now, this artery is closely related to the cords of the brachial plexus and its branches, isn't it? Now, again a question to you. Why do we call upper trunk and middle trunk and lower trunk? But when it comes to cords, we call them as posterior, medial, and lateral cords. when we could have just called them upper, middle, and lower chords. Why do we call it? Why do we call them, chords as posterior, medial, and lateral? Because you will tell me the answer in the next class, because I've already explained it. Right now, as I told you, the axillary artery is closely related to the cords of the brachial plexus and their branches, and is enclosed with them in a connective tissue sheath called as axillary sheath, which in itself is a 3-marker question. Okay, this sheath is traced upward into the root of the neck, and it is seen to be continuous with the prevertebral fascia. When we do head and neck, I'll teach you about different fascias. I'll teach you about dangerous space of neck, so on and so forth. For now, remember, axillary sheath continues with prevertebral fascia. Now, what are the different parts of the axillary artery? Number one, first point that you have to remember is pectoralis minor is the muscle that crosses in front of the axillary artery and divides it into 3 parts. Okay, pectoralis minor muscle divides the axillary artery into 3 parts. The first part lies above the pectoralis minor muscle. The second part lies behind the pectoralis minor muscle. Third part lies below the pectoralis minor muscle. Okay, above, behind, and below. First part of the axillary artery extends from the lateral border of the first rib to the upper border of the pectoralis minor. It is bounded anteriorly by the pectoralis major and the skin, posteriorly by the long thoracic nerve. Long thoracic nerve is nerve to serratus anterior, injury to which leads to, question to you, homework question number 2. Yes. Laterally, it is related to all the 3 cords of the brachial plexus and medially to the axillary vein. Okay. Yes. Then the second part of the axillary artery, it lies behind the pectoralis minor muscle, anteriorly pectoralis minor major and the skin, posteriorly posterior cord of brachial plexus and the subscapularis muscle and the shoulder joint. Laterally, it is related to the lateral cord of the brachial plexus, medially to the medial cord of brachial plexus. I think I've already answered your first homework question as to why the cords are called posterior, medial, and lateral. By now, you should have figured it out. Yes. The third part of the axillary artery extends from the lower border of the pectoralis minor to the lower border of the teres major. Okay. Relations: pectoralis major for a short distance. I'm sorry. Yeah. Pectoralis major for a short distance, and lower down the artery is crossed by the medial root of the median nerve. Homework question number 3. What is the root value of median nerve? Okay. Homework question number 4. What happens when there is an injury to median nerve? Okay. Yes. So these are the 4 questions that I've asked. I expect an answer in the next class. Yes. Posteriorly, the subscapularis and latissimus dorsi in teres major. Again, guys, look at the pattern over here also. Anteriorly, the third part is bound by pectoralis major. Posteriorly, the same muscles. The same muscle, subscapularis, latissimus dorsi, and teres major. The reason why I have kept this class today towards the end is to show you the kind of pattern that exists in anatomy. Okay, to show you the kind of pattern. You were studying the boundaries of axilla, right? Now you are studying the third part of the axillary artery. What are you seeing? The boundaries and the relations are the same. This is how it is in anatomy, guys. This is how the anatomy needs to be studied and it needs to be approached. Okay, you'll have to find that pattern. You'll have to find that the way the things are, there is a certain pattern in which the things are set. You just have to figure it out while studying anatomy, and you will score distinction if you do that. Most of the students find anatomy difficult because they try to mug up things. They try to mug up. See, right now itself, I've kept this slide particularly towards the end to tell you. Initially, when I taught you the walls of axilla and the relations of axilla, and now look at the third part of axillary artery. Are you able to see a pattern or not? Until now, in all my classes, I've tried to point out those tiny little patterns that we find out. because everything is related in human body. Nothing happens in isolation, isn't it? All you got to do is just figure out that pattern and anatomy becomes so easy for you. All right. Now, let me just finish the third part of axillary artery. Laterally, it is bounded by, see, coracobrachialis, biceps, and the humerus. Medially, ulnar nerve, axillary vein, and the medial cutaneous nerve of arm. Again, guys, which is the medial nerve in our human body, in the upper arm? Ulnar nerve, isn't it medial? Ulnar is medial or lateral? Ulnar is medial. Radial is lateral. So what do you expect over here? What should be the medial relation? Ulnar nerve, right? Even if you don't know anything, you should have a rough idea as to how to answer that particular question. Example over here. You see, medially, I'm telling you, the third part of axillary artery is closely related to the branches of the cords. Meaning, in this, I cannot write anything about the branch. Sorry, I cannot write anything about the cords. I'll have to mention about the branches. In the medial relation, what nerve can you expect? Obviously, the ulnar nerve. Just apply logic. When I was teaching shoulder movements also, which most of us find extremely difficult because we try to mug up, we try to, make mnemonics, because that has become a trend these days. Make a mnemonic for everything, because I don't, I'm particularly not against a student making a mnemonic, but the process of making mnemonics itself will eat up your brain space. Other than that, apply logic where you can apply logic. For example, even today, I remember that the adduction of the shoulder is brought by what? Pectoralis major muscle, because something needs to contract over here to pull my arm, isn't it? So similarly, look over here also. Medially, you have the ulnar nerve, axillary vein, and the medial cutaneous nerve of arm. Okay. This is the third part of the axillary artery. So the axillary artery is divided by the pectoralis minor muscle. Now, the pectoralis minor muscle, after it divides the axillary artery, it is divided as above, behind, and below the pectoralis minor into as three parts. The first part, these are the relations. Second, these are the relations. Again, the same things, guys. Anteriorly, skin, pectoralis minor and major. Why? Because muscles will not change. Pectoralis major and minor forever will be anterior relations of whatever it is. They can never be a posterior relation, because nothing is there in front of pectoralis major and minor muscles except for the skin and superficial fascia. Isn't it? This is the pattern that you will have to identify in anatomy. Once you get these patterns, these tiny little things, this is where the magic happens. Okay. Yes. So that's it. It's a very, very simple and a small topic, axilla and axillary artery, which I thought, is important. And if you go through this, it'll be immensely helpful. Now, coming to the second half of my class, that is how to approach a 10 marker, a 5 marker, and a 3 marker questions, and how to approach the practical examinations, histology, and holding your nerves. Number one, a long essay will begin with some clinical case scenario. Okay? A long essay will always begin with some clinical case scenario, and with the kind of examinations that are coming up, right? We are now talking about integrating anatomy with surgery, integrating anatomy with orthopedics, isn't it? So the next exam, which is upcoming, that we are having, you will expect lot more clinical scenarios. I mean, you can expect a lot more clinical scenario based questions. This is what my hunch is. The questions that will be asked will not be extremely theoretical. It'll have a tinge of practicality as well. Okay. So in a 10 marker question, let us say, for example, I am asked a question about brachial plexus. Okay. By looking at the clinical scenario, I found out that is a question is about brachial plexus. The first line, the introduction to the answer, should always be the definition. Okay. You'll always have to define what is asked. So that is a basic thing. Whether they have asked for definition or not is not important to me. I'm going to start my answer with the basic definition. Okay. First, you write the definition and you define whatever that is asked. They may ask about medial nerve injury, they may ask about any nerve injury, they may ask shoulder joint dislocation. First, you define what is being asked after you make a diagnosis. After this, you will make a very small line diagram, simple one. Okay, simple line diagram. Okay. After this, they would have asked, let us say, for example, if they're asking about brachial plexus, they may ask about relations, they may ask about chords, they may ask about branches. What will you do? You will make a simple line diagram. Now, for me as an examiner, if I'm correcting that paper, I see that the student has written definition of the answer, I mean the basic definition, and he has made a diagram. Correct? By looking at these two, I get an impression that this student must have studied this particular topic. That's why he's writing about definition and there's a diagram also. So I ease up my I sort of ease up my mind, and because I've already formed an impression as an invigilator, as an examiner, that these students know something about this topic, because you would have made a simple line diagram, easy to identify, nothing fancy, nothing colorful, just a line diagram, simple, and you've defined it. After this, go specifically to those points that are asked. Do not beat around the bush. Don't write 100 things about brachial plexus. Don't write about median nerve injury, radial nerve injury, and everything right in the starting, right in the beginning itself. See what the question is. If they are asking about brachial plexus and its structure and its relations, make those headings and write below the headings in form of bullets, in form of arrow mark. Just make a small arrow mark like this and write. Don't jumble up. It is so irritating to look at a paper where the student hasn't made written answer in the form of points, in the form of bullets. They just write hundreds and hundreds of pages of answers, and then they just cramp up everything in just one page, and it's so annoying to to find out the answer that you are looking for. Don't irritate the examiner. Rather, just look at what is being asked and write the answer in the form of bullets and form of points. Okay. If you can make a table, well and good. If you have that much time, if you don't have that much time, don't waste your time drawing those lines and everything. No, don't waste your time. Let the paper be very neat and tidy, but you don't have to waste your time in making your answer sheet look like a Ravi Verma's painting. We don't need that. Okay. Then come straight to the point. Don't beat around the bush. If you don't know the answer, just leave the question, but do not beat around the bush and irritate the examiner. If the examiner gets irritated in the very first question, then obviously it's going to have a negative impact on the rest of your paper. So do not beat around the bush. Don't know an answer, fine, chill, don't have to answer it. There are plenty of other questions. Okay, so answer specifically, answer in bullet form, point form, or in a flowchart form, as you feel is, as you are comfortable. Okay. Yeah. And then after writing 2 3 paragraphs, again depict, let's say for example, if you're trying to show what the relations of brachial plexus is, first always write the diagram and always have the markings on one side, not on two sides. Write a diagram, have markings on one side, because then the diagram looks very neat. See, the effort is the same. You're going to mark the diagram, just mark it on one side, na? Okay, mark it on one side. So effort is it same, and the time taken is also the same, and it doesn't matter, isn't it? So, and point number one to remember over here is specific answers, no beating around the bush. Number two, make simple line diagrams. You don't have to be Ravi Verma, and don't keep on coloring and shading. No, we don't want that. Simple line diagrams with one side markings. Done. Number three, clinical anatomy. Guys, I can't stress this enough. Clinical anatomy is something that will fetch you at least 1 mark. चलो ठीक है, कुछ भी नहीं आता. Let's say there's a question on joints, shoulder joint. Just write shoulder joint dislocation leads to serious complications. You may not know about Bankart lesions or recurrent shoulder dislocation. You may not know any of this, but at least इतना तो लिखो. ठीक है? Yeah. So this is a generic way of answering your paper. Now coming to specifically, whenever a muscle is asked, okay, any muscle, let's say pectoralis, major muscle is asked, you will have to describe a muscle under the following headings: origin, insertion, nerve supply, action. 4 headings: origin, insertion, nerve supply, action. 5 is clinical anatomy. Clinical anatomy, whenever a muscle is asked, a standard thing that you can always write is about the if blood supply to the muscle is cut off, it results to necrosis of the muscle. I mean, it's very, you shouldn't be writing it, but I'm just saying this is how I used to answer in first year, and I've got very good marks in anatomy. Okay, and then write specific, let's say, now for example, Samantha is a film actress, right? And most of us know she works in Telugu, and the family man Samantha, now she has a condition. What is that condition? I'm sure you know better than I do. So I mean, it's a little, myositis is little, high level stuff, but still, if you can draw these practical conclusions, inflammation of muscles and things like this, fine, well and good. But if you don't know, you can always write. Let's say, for example, if you cut off the arterial supply to the muscle, it causes necrosis of the muscle. If you cut off the nerve supply to the muscle, it causes paralysis of the muscle, irrespective of which muscle in the body. I'm just giving you these small little tricks. ठीक है ना? So whenever a muscle is asked, 5 different headings, 1 line diagram. Okay, origin, insertion, nerve supply, action, clinical anatomy. Clinical anatomy, standard 2 points: loss of arterial supply, loss of nerve supply, paralysis, necrosis. Standard. Don't change anything. If you know the artery that supplies a particular muscle, well and good. Okay, or if you know a condition that results in the paralysis of that particular nerve, or the injury to that particular nerve. Let's say there is a fracture of shaft of humerus, it causes radial nerve injury. Radius supplies what muscles? It supplies all the posterior, the, let's say, triceps and the flexor compartment of extensor compartment of forearm. So if you know specific muscles, then you can always say ki injury to this particular nerve in these conditions results in the paralysis. Okay, otherwise it's generic 2 lines, so you can definitely write for muscle. Muscle is done. If an artery is asked, okay, if an artery is asked, you will have to write about how the artery begins, origin of the artery, termination of the artery. Okay, example, axillary artery starts starts from subclavius and ends and continues further down as brachial. That is your first point is origin and termination. Second point is its relations, isn't it? Second point is the relations of the axillary artery, okay, or any artery for that matter. Third, structures that it supplies. Third point, very important, structure that it supplies. So you've already written an artery in a proper in a proper specific points, so that when an examiner looks at this, he feels very happy, right? You've covered all the important point that is required of you in a very simple and nice way. All right, so that is about artery. And then of course, injury to artery results in necrosis of the muscles or the structures that it supply. Or you can write, whenever an artery is asked, you can write about atherosclerosis. Atherosclerosis happens in every artery, may not be in coronary. I mean, coronary artery is not the only artery where you have atherosclerosis. Or you can write about vasculitis, because vasculitis is again inflammation of arteries, right? Vasculitis, you can write about vasculitis. There are many conditions like Takayasu arteritis, there is Jain cell arteritis, there is eosinophilic granuloma formations, and so on and so forth, that you will study in pathology. But you can mention ki inflammation of arterial wall is called as arteritis, isn't it? And just make a small histology diagram also. So if an artery question is asked, origin, termination, relations, structure supplied, clinical anatomy, and a Kutti histology diagram. Done. If you write answers like this now, out of 5, you will at least get 4 to 4.5 marks. Okay, na? Then come to nerve. Nerve, again, first point that you'll have to write is the root value. Root value is very important. Let's say upper limb nerve is asked, then the first thing you have to write about is the root value. Second, it's a branch of which cord. Okay. 3, relations. 4, structures are the muscles it supplies. 5 is branches. Again, sorry, I forgot about this in the artery section also. In an artery also, you'll have to describe branches if it is giving off any, which most arteries do. Okay, if it is taking part in any anastomosis, you can mention that as well. All right. Yeah. So in nerve also, same thing. Introduction, root value, branch of which and which, then come to the branches, then come to relations, then come to structure supplied, then come to clinical anatomy. Clinical anatomy, injury to nerve results in muscle paralysis. Right? Muscle paralysis. Okay. So how many things have we covered? Muscle, artery, nerve. What else can they ask? What else can they ask in anatomy as such? They can ask about veins is very veins and lymphatic drainage is, you may expect just one or two questions, not very important. Lymphatic drainage of breast is important. If you talk about venous drainage, median cubital vein is the most important one in upper limb. And again, same, the pattern remains the same. So if a 10 marker question is asked, you'll have to write three to four diagrams and describe everything in detail. 5 marks, one or two diagrams. 3 marker, generally they don't expect any diagrams, but if you know any, you can write one diagram. And if I have to talk about the number of pages in which you have to fit in the answer, 10 marker should be this side one page, this side one page, turn it maximum 3 pages, 1 2, turn it this one page. 5 marker, maximum 1 2. That is maximum, I'm saying, guys, maximum. Don't stretch your answers beyond that. 3 marker is half a page. 10 marker, 1 2, and this, if possible, just fit the answer in only these 2 pages. 5 marker, 1 2 maximum, or just one page. 3 marker, half a page. Okay, always start the answer from a fresh page. That is a 10 marker, always start from a fresh page. All right. Then how to approach a practical examination. So practical examination, guys, in osteology, I'd already told you, you have to pick up the bone that you are comfortable with. Okay. Practicals will be generally very easy and they don't fail anybody in practicals in most part of India. But sometimes, if you're too bad, if you don't know anything, yes, you're bound to get failed. Basic knowledge, if you have on anatomy, very, very important. So, number one, osteology, we have already covered. Pick up a bone that you're comfortable with. Number two, if in spotters, again, be very specific. If you don't know a spotter, just leave it. Just leave it. Do not beat around the bush. Do not write 100 things. Okay, if you don't know a spotter, let it be. It's okay. Move to the next one. But do not write, if they're asking about brachial artery, do not keep on describing radial and ulnar arteries. Don't do that. Don't know anything, leave it. Okay. Then embryology. Embryology is very easy because you have limited number of specimens in embryology. So just before the exam, when they do the final revision, take the pictures of all the specimens you have and sit with your friends and you teach them. You pick up a specimen. Let's say, for example, they are asking you about formation of a blastocyst. Okay, or they are asking about the uterine wall implantation, or they may ask about somites. For example, somites is a specimen that is there in all the colleges. Now just make your friends sit and teach them everything about somites, everything about notochord, everything about whatever the specimen that are there that have been taught to you in your class. Okay, then comes the x-rays. X-rays again are very easy. There'll be a chest x-ray, one shoulder joint dislocation x-ray, and they would have shown you all this in your classes. So have a proper memory of that, or take pictures and keep revising it. Okay, don't do like you've done this classes in January and now I am doing this day before the exam. Don't do that. Keep seeing those pictures again and again and again. Okay, that is when the practical exam becomes easy. Then, how to study histology? Guys, histology is something that we again tend to forget because it's all pink and blue. Until and unless you become a specialist, it is pink and blue for all of us. Okay, so how to study histology is like, again, practice. Go to Google, see different images of this same specimen. For example, cartilage is a very important slide, isn't it? Or pancreas is a very important slide. In your college, you generally look at the microscope and take a picture and keep it. Now, same, let's say you have 20 specimens, look 20 different images, right? Let's say, for example, pancreas, one picture, you always have the standard one that you take from the microscope, okay, that you anyway have. But also look at other images, that are available online of the same picture, right? So that makes histology very easy. And one more thing, when you have histology practicals, keep practicing the diagrams also. Every now and then, in your histology class, just open the pages, go back and see, oh, this is how a cartilage looks. Then look at the diagram, go to the microscope and see the specimen again. Not this is not the first time I'm talking about. Again, when you are sitting in your histology classes, just go and see the specimen again after you see the diagram. So then you will understand it better. Again, practice makes a man perfect. Repetition is the key. Okay, repetition is the mother of all skills, guys. Seriously, if you keep repeating, if you keep studying again and again and again, will only then you pass the examination. Otherwise, anatomy is tough. Number one point in anatomy how to pass is, number one, always find a pattern. Okay, always find a pattern in whatever you are studying. Number 2 points, be smart. Number three, keep repeating the same things, keep revising the same things, keep repeating the same things with your friends, teach them, sit with them, discuss with them, and keep revising. Revision is the key. Okay, then lastly, how to keep calm during examinations, guys. I mean, listen, I'm not being very philosophical here, but exams in your life is just a very little small part. Like now, right now, if I look back and think about my first year examinations, I know how terrified I was. And even let's say I had failed my practical examination or failed my theory examination, let us say, for example, would it have mattered to me? I don't think so. I would have done 6 months extra of MBBS. But how would it have affected my life in any way negatively, let's say 10 years down the lane? Doesn't matter. Really doesn't matter. I mean, you may think ki ma'am is saying this because she's already done this, but this is the truth. Okay, this is the truth. It really doesn't matter how much marks you've scored, how many attempts you've taken, and all that matters is what is here, what is going here, and how you are translating this knowledge into treating your patients. Exam is not the key. Exam is a very small part of your life, but during your clinical practice, using the knowledge that you've gained over here, how many patients are you able to save, or how many patients are you killing? This is what differentiates. This is the differentiator, and not your first year examinations. All that matters is what you're studying, how much of that knowledge is going here, how much of that knowledge is getting translated into your clinical practice. That is the real test. Every patient that comes to you, sits in front of you in OPD, is the real test, not these examinations. Even though it may sound very philosophical, but if you look at it 10 years down the lane, like I did my first year MBBS how many years back? 8 9 years back, 8 years back, right? So now if I look at it 8 9 years back, and now it hardly matters how much marks I've scored, but all that matters is that the knowledge of anatomy that I had gained back in first year is helping me immensely in my clinical practice, helping me immensely in my diagnosis, isn't it? So that is all that matters. That is all that matters, and that is the truth. Okay, you may not realize it today, but you will come back and tell me in 5 6 years ki ha, yeah, what ma'am said was right. Okay, yeah. So I think with this session I'm hoping that I've cleared most of your doubts vis-a-vis examination as such, your anatomy examinations as such. And I really hope that you found my upper limb sessions useful and resourceful, and you can follow us across all these social media handles, and if you have any doubt, you can reach out to me. And from next class onwards, we will be starting with neuroanatomy, and I really wish you guys all the very best. And if you have any doubt, of course, you can follow us and you can reach out to me here, and I'll be more than happy to help you in any which way possible. Okay, and thank you so much, guys. So thanks a lot, guys, and I wish you all the very best. And that's it from my side today, and I'll see you in next class. Good night, guys. Thank you.